Good morning, everyone. Welcome to 69th International Weekly Meeting on COVID in association with SIMAO. I also say good evening for a lot of speakers. So a lot of people over here who have been joining from the different part of the world, especially the speaker who has been joining at the midnight. So thank you for joining in. We are on 31st July, 9:30 a.m. Indian Standard Time. We have been working on a lot of issues today, considering the third wave we are expecting to come in, and a lot of questions are coming on vaccination. We have covered a lot of topics on the vaccinations, how it's going on. Today, we have a very important topic, again, on COVID vaccination in transplant patients. To present this topic, I have Dr. Brahm Vasudev. He's a director and associate professor and a nephrologist of Center of Advanced Care, Medical College of Wisconsin. He has pursued his medical degree from Armed Forces Medical College in Pune, completed his residency as a chief residency year in internal medicine in Brookdale University of Medical Center and critical care fellowship at Albert Einstein University in New York. He has then completed both nephrology fellowship and transplant nephrology fellowship at Medical College of Wisconsin in Milwaukee. He is also an associate professor of Medical College in Wisconsin. Prior to this program, he has served as a Disease Transmission Advisory Committee, DTAC, for Organ Procurement and Transplantation Network. Over to Dr. Brahm Vasudev for the presentation.
Good morning, everybody. My name is Brahm Vasudev. Thank you for this opportunity to present today. And thank you, Saurabh, for the invitation. I'm going to be talking about COVID vaccination in kidney transplant recipients. I'm going to share my slides. So give me just a minute. All right, so can you see the slides okay?
Yeah. Perfect.
Oh, wonderful. So it's projecting on the full screen. Wonderful. So once again, thank you for the invitation. I am going to be talking about this very important topic, at least in the field of organ transplantation, especially during these pandemic times. It's good that the vaccine is available now, and people who are not immunocompromised and get the vaccine have good response, and vaccine is certainly, offering protection to a lot of immunocompetent people. But I'll tell you the story about transplant patients and how they are different from the general population. This is my disclosure slide. I also want to mention that a lot of information related to COVID pandemic is changing very rapidly, and what's true today may not be true tomorrow. And the guidelines are constantly changing. And I think, we being responsible global citizens need to understand that this is normal because this is new. There are more and more study data that are coming out. So the information is going to constantly change with time. So what I'm going to do today is that I'm going to review a summary of COVID vaccine efficacy and safety and some clinical trial data related to this vaccine in transplant patients, and what are the lessons we've learned from the pandemic so far. Then I'm going to talk a little bit in more detail about the specifics of COVID vaccine in solid organ transplant recipients. And then I'm going to discuss some of the questions that these transplant patients frequently ask us in the clinical setting. So there are lots of different kinds of vaccines that are available: DNA-based, RNA-based, inactivated, viral vector vaccines, the subunit vaccines, and the live attenuated vaccines. And different people in different parts of the world have access to different kinds of these vaccines. What I am most familiar with in the part of the world that I live in is the Pfizer vaccine, the Moderna vaccine, which are both mRNA vaccines. and also the Johnson and Johnson vaccine. These vaccines have, at least in their secondary outcome, they've shown very good results. 83 to almost 100% chance of preventing, severe COVID infection. And then as far as preventing symptomatic infection is concerned, it seems that Pfizer and Moderna seem to be doing a little bit better compared to the Johnson and Johnson vaccine. And these are the three vaccines that are primarily available in US. So most of the data that I'm going to share with you relates to these vaccines. Now, it is very important to understand, and you probably are all very familiar with this, is that you know the data related to these vaccines is very interesting in the sense that there is no trial that has compared the efficacy between vaccines in the same study and at the same time. So it's not that Pfizer is being compared to Moderna. These vaccines have been done in different times, or the vaccine studies have been done in different times. They have been done in different geographic locations. The strains of the virus that might be circulating in the area where these studies were done could be different. The precautions that people were taking at that time could be different. So it is very hard to interpret the efficacy data of these vaccines because the playing ground is not the same for all the studies. But the other thing is that these vaccines have demonstrated high efficacy in preventing severe disease requiring hospitalization. And another very good thing is that in the vaccination trial, no participants who received the vaccine died from the vaccine, and that's, I think, very important to know. So a few of the lessons that we've learned are, of course, that COVID preventive measures have clearly been very, very important in prevention of infection. We are all familiar with the symptoms that the COVID causes in general population. And we are also aware that there is a lot of hidden morbidity and mortality related to this pandemic. A lot of people who needed healthcare have delayed their healthcare because they don't want to go to the hospital and catch an infection. The COVID has certainly overburdened the healthcare systems and continues to do so. And then there have been a lot of social consequences to these infections. Most of the physicians who are employed in the hospital or they have their own practice, they have probably not borne the brunt. But a lot of other people who are not so well off or don't have stable jobs, they've lost houses, food supply has been an issue. People have had their jobs at stake. Socialization has certainly gone down, and travel as well has suffered a lot. We have recognized that there are certain risk factors for developing COVID infection or severe COVID infection, and these include things like cancer, chronic kidney disease, heart disease, lung disease, diabetes, smoking, obesity, having an immunocompromised status, and so on and so forth. There are lots of treatments that have come and gone. Nothing has been a very clear winner, I must say, but the efforts go on, and there is still a lot of pharmaceutical companies that are working on producing medicines that might be effective in treatment of this condition. We do know that about 50 to 80% of the patients can continue to have bothersome symptoms 3 months after the onset of COVID. And there are all these talks that even you guys have had on your presentations on brain fog and other comorbidities that predispose people to become long haulers. Despite the availability of vaccine, there is unfortunately still a lot of vaccine hesitancy. We are seeing here it in US as well. There are a good number of people who still don't believe that there is this pandemic going on and feel that it is a hoax, and therefore we are nowhere near achieving herd immunity in United States at least. Now I'm going to talk a little bit about the current state of knowledge that we have related to COVID vaccine in solid organ transplant recipients. And I'm going to cover these three important topics. One, to review the immune system and the immunosuppression that we use for these solid organ transplant recipients. And then I'm going to talk a little bit about COVID implications in solid transplant recipients versus non-solid organ transplant recipients, and how do these solid organ transplant recipients respond to the COVID vaccine. So I'm going to start off with this very basic slide, which is very well known in our field. This is called the three signal theory of rejection. And what this slide shows you is that when we transplant an organ, along with an organ go the dendritic cells that express the HLA proteins of the donor. So at some point when the circulation is restored in the transplant, these dendritic cells come in contact with T cell receptor of the recipient. And that leads to this signal, which is called the signal 1, where the MHC bound peptide on the dendritic cell is recognized by the T cell receptor, and it realizes that it's a foreign protein. To confirm that the protein is indeed foreign, there is a series of signals that occur between the dendritic cell and the T cell called the co-stimulation signals, and I'll show them in a bit in the next slide. Once it is confirmed that the protein is foreign, the T cell produces T cell growth factors, essentially interleukin 2, interleukin 15. And these factors, once they are produced, they make this T cell proliferate. So this T cell then transforms into either a helper or a cytotoxic T cell, and then it goes back into the organ and starts damaging the cells that express the same HLA antigen that triggered this signaling pathway. So here's a nice cartoon showing the MHC bound peptide. This is the red peptide that you can see, and this is recognized by the T cell receptor. This is the signal 1. And then there are a bunch of co-stimulatory signals that you can see here that confirm that indeed this protein that the T cell receptor recognized is foreign. And once that confirmatory steps occurs, the naive T cell becomes an active T cell and starts to proliferate. This slide shows you the same concept, that once these lymphocytes are stimulated by an antigen, they can either transform into T helper cells or cytotoxic CD8 positive T cells. And then these T helper cells can also present the antigen to the B lymphocytes, which then starts making antibodies. So the transplanted organ is recognized as a foreign tissue, and therefore whenever we transplant, our body sort of launches an immune attack towards that organ. And the virus is very similar. You know, when the virus enters the body, it launches the same response in the human body. Now, in transplant recipients, the only way that the transplants can survive in their body is if we suppress their immune system. And this slide shows the immunosuppressive drug timeline, and you can see that the steroids were available in 1950s. Things like Imuran came about in 60s, cyclosporin in 83, 84, tacrolimus and MMF type drugs came around 1995. And year 2000, we saw a bunch of monoclonal and polyclonal antibodies, as well as the mTOR inhibitors. And then belatacept, which is a co-stimulator blocker, was approved in 2012 for immunosuppression. And what these immunosuppressive drugs do is that they essentially block this proliferation process at multiple points. And this is important. It's important that we use more than one medicine, because if we only use one medicine, the immune system will bypass it. But if we use multiple medications, this process is inhibited at multiple steps, and we can be successful in preventing this T cell proliferation and therefore rejection. So now we have a bunch of immunosuppressive agents available. Most of these drugs are generic and available all over the world. They're not necessarily very expensive. And what has come out, and this slide shows it very nicely, is that there is a standard 3-drug regimen that most transplant centers follow, which includes tacrolimus, mycophenolate, and prednisone. So if you can see in these graphs, the top blue line reflects this regimen of tacrolimus, mycophenolate, mafetil, and prednisone. And you can see whether somebody has a kidney transplant, a liver transplant, a heart transplant, or a lung transplant. This is the most common regimen used all across the world for immunosuppression. And it also happens to be the most potent regimen that we can use to suppress the immune system so as to reduce the risk of rejection. So when transplant patients get COVID, how is it different from people who are immunocompetent? So one of the things that is common with general population is that the symptoms are very similar: fever, cough, diarrhea, which is what essentially happens in general population. But what is unique in transplant patients is that if they get hospitalized, they have higher incidence of acute kidney injury compared to non-transplant recipients. And if you especially think of kidney transplant recipients, first of all, they have a single kidney, and general population people have two kidneys. So the kidney function is anyway low to start with in transplant population. So they have chronic kidney disease to start with, and when they get sick, they definitely have a higher incidence of acute kidney injury, and they can lose their allograft because of their acute kidney injury. In terms of hospitalizations and intensive care unit admissions, you can see the numbers are not too different from general population. There's a range of 30 to 70 odd % patients who get admitted if they have COVID. And if once they are hospitalized, the risk of going into the ICU is almost about 20 to 30% in this particular population, which is a little bit higher than the general population. We also see that their intubation rates are close to about 30 to 40% in larger studies. So, a good percentage of them get intubated if they are sick. And once they get intubated, they generally have poorer outcomes compared to patients who do not require intubation. And in terms of mortality, most studies have shown a mortality of almost 20 to 30% in this population. So that's fairly significant compared to the general population. So what are the implications of COVID-19 in these solid organ transplant recipients? So there was a very good study that came out of University of Washington. It was called the UW COVID-19 SOT study. And what they did in this study is that they looked at close to about 482 transplant patients and looked at their 28-day mortality after they've gotten this COVID infection. And what they realized in this study, that the primary driver of mortality in transplant patients is not the immunosuppression they are on, but it is actually the comorbid conditions. So, many people who get a kidney transplant, a lot of time they're diabetic, they have high blood pressure, they have, other comorbid conditions which predispose them at higher risk of mortality compared to non-transplant recipients. So this is what this study found, that essentially what drives mortality in transplant patients is their age and their comorbid conditions like congestive heart failure, diabetes, obesity, and so on and so forth. So this was a very good study that essentially said that it doesn't matter what immunosuppression they are on at the time they catch COVID, it is essentially their comorbid conditions that drives their mortality and morbidity. This is another study by Yusuf Hadi from University of West Virginia. And what these people did is that they did a very interesting study where they looked at about 2,307 transplant patients and who had COVID, and compared them to almost 320,000 non-transplant recipients and looked at the mortality in either of these two groups. And they did propensity matched analyses, and what they found was the same thing that the previous study found, that the increased mortality in these patients is primarily a function of their comorbid conditions and not the immunosuppressive medications they are on. There are a couple of other studies that have looked at antibody formation in kidney transplant recipients who get COVID infection. And there are two studies that I have shown on this slide. One is a smaller study with 7 transplant patients who got COVID, and they all developed IgG antibodies between 5 and 27 days of symptom onset. There was another study that looked at a larger pool of patients, about 35 kidney transplant patients who got COVID. And of the 29 who survived, all of them developed IgM or IgG antibodies 14 days after the onset of symptoms, and these antibodies could be detected even at day 69 after the infection. So we do know that in response to infection, these transplant patients will make antibodies. They also looked at the safety of this vaccine in transplant patients. So we've known that this vaccine is safe in general population. They looked at the safety of this vaccine in transplant patients and found that the safety profile is very similar in transplant patients compared to patients who don't have a transplant and got the vaccine. And there was no signal at this time for increased risk of rejection or any of the neurological complications related to the vaccine. So it's deemed very safe in our world. So, when the original trials for COVID vaccines were done, the transplant patients were not enrolled. So the initial EUA that came out, it did not include the transplant recipients. But right after the vaccine was available for use, one particular center in the East Coast by the name of Johns Hopkins started a study collecting samples, pre-COVID vaccine sample and post-COVID vaccine sample for antibodies in a pool of patients. So this is the slide that shows their data in close to about 1,112 patients who were transplant patients who got their first COVID vaccine. And what they showed in this data is that the response rate to the vaccine was actually not very good. Unlike general population, where a large number of people respond to the vaccine, the transplant patients, only 17% of them made antibodies after vaccination. So this is a really poor response. Now, the vaccine that they studied in this particular study were either Pfizer or Moderna, which are both the mRNA vaccines, but the response rate was very poor. So what they did is that they continued to follow these patients and looked at the antibody response after the second dose of the vaccine. And after the second dose, about 54% of the participants actually had measurable antibodies. So after second dose, a higher number of patients responded to the vaccine, but nothing like normal population where you see responses in the rate of 90 to 100%. So once again, it shows that even though we inject this abnormal protein into the body, because of immunosuppression, the transplant patients are unable to launch an immune response that at least we can measure by the antibodies. So what about the Johnson & Johnson vaccine? So they did a similar study in a smaller group of patients, and what they found that the Johnson & Johnson vaccine had even poorer response compared to the Moderna or the Pfizer vaccine. So those vaccines, the mRNA vaccines, had a 56% response rate, and with Johnson & Johnson, the response rate was only 20%. And not only was the response rate less, when you measured the median titers of the antibodies, they were much lower. Now, I understand we don't know what exactly these titers mean. We don't have a cutoff or the right threshold, But nevertheless, the titers of the antibodies were less with Johnson & Johnson. So we generally are not recommending our transplant patients to take Johnson & Johnson. We are recommending them at this point to take the mRNA vaccine. There is another transplant medicine that is used in US. It's a co-stimulator blocker called belatacept. This medicine is also available for use in Europe. And there was a study where they specifically looked at immune response to the vaccine in patients who were on this drug called belatacept. There were not a lot of patients. They had about 100 patients in the study. And the good thing, however, was that they looked at both the antibody response as well as the T cell response by tests like ELISpot. And what they found was, very similar to what we found in the other studies, that barely 5.7% of these patients who were on this particular immunosuppressant developed antibodies at the end of 60 days. And then only 30% showed a T cell response at the end of about a month or so. So again, it shows that even with this medicine, the response rate is unfortunately very poor. There are lots of other studies. I won't go over all of them, but I have listed them on this slide. And these are from different parts of the world, Asia, Europe, US, South America. And they're all consistently showing the same thing, that transplant recipients do not have a good antibody response to these vaccinations, which is very unfortunate. Because these people can get very sick if they catch this infection. So what do you do if they don't respond to the second dose? So this is a small study that just came out this month in New England Journal of Medicine. This is a study that came out of France. They had about 100 patients in this study. They looked at them retrospectively. And these are the patients who'd gotten the third dose of the mRNA vaccine, specifically Pfizer. And what they noticed, and you can see that in the graph below, is that you can see that these patients had no antibody level before the vaccine. They had about a 10% response rate after second dose. They had about a 45% response rate after second dose. And then after the third dose, the response rate in terms of measurable antibodies went up to almost about 70 to 80%. So they, at least in a small series, showed that it is safe to give this third dose, and you can expect an increased response in patients who've gotten the third dose. And therefore, there is a case being built now to give the third booster dose in kidney transplant recipients at the very least. The FDA has still not made that decision, but we are hoping that hopefully this fall, there is a possibility, especially now since the vaccine is more freely available, that it will be offered as a booster dose to people who've not responded. So what are we missing with COVID in transplant patients? One is that there is no consistent standardized way to measure antibodies, and different labs and different centers are using different parts of the viral protein to measure the antibodies. We don't know what the threshold for the neutralizing antibody is. Is the higher the level better, or is there a certain level which would be protective irrespective of what that level is? We don't know what's going to happen over a period of time. It is possible that these antibody titers wane over a period of time. But again, time will tell. And then we still need more data to evaluate the efficacy of the COVID vaccine and its effect in preventing severe COVID disease in transplant recipients. And again, what is the best approach to the blunted response that these people have to the vaccine? Do they need a booster dose? Should the vaccine be at a higher dose? And then what is the optimal time when patients should get this vaccine after transplantation? We know that if we give them vaccine within the first 3 months of transplant, generally the chance of responding is almost zero. And we do know that patients who've had their transplant for at least about 5 to 6 years tend to launch a better immune response. And should we modify their immunosuppression at the time of vaccination, holding one of their immunosuppressive meds for some time, but we don't have clear answers yet. And we also don't know what the variants will do in this particular population. Now I'm going to go over some of the common questions that we get asked in the clinic by these patients. One is that if they get a vaccine, like let's say a transplant patient gets either a Pfizer or a Moderna vaccine, and then develops COVID infection within a few days of that vaccine prior to them getting the second dose, should we wait? How long should we wait for the second dose? And generally we tell patients that you should wait until your acute illness subsides, whether it's 4 weeks or 6 weeks, whatever time it takes, but you have to recover from the acute illness before we can give you the vaccine. Or at the very least, you meet the criteria where isolation can be discontinued, which is typically 10 to 14 days after the onset of symptoms. Another question that we get asked is that, can they take COVID vaccine with another vaccine? And this is going to become an issue as we approach the flu season. And the answer from the CDC is that yes, more than one vaccine can be administered at the same time. So somebody could get a flu as well as COVID vaccine. Obviously, we recommend that the injection occurs at different site, one in one arm and the other in different arm if possible. And if that's not possible, at least there should be a 1 to 1.5 inch distance between the two vaccination sites. Another question that we get offered is if they've gotten one dose prior to transplant, when should they get the second dose? So let's say somebody gets a vaccine and their name comes up for a deceased donor kidney transplant within a few days of the first vaccine, and they've not gotten their second vaccine. When should they get their second vaccine? And generally we tell them it's a function of what kind of an induction agent they've gotten at the time of transplant. If they've gotten a T-cell depleting agent, then we obviously recommend a longer wait time. And if they've not gotten a T-cell depleting agent, then generally we can give the vaccine within a 6-week period of the transplant. Another question that we get frequently asked is that transplant patients, they know that they're not likely to make antibodies. And many of them, after they get their 2 shots of vaccine, ask us if they can get the antibody test. And the general recommendation we have for them is that we would not recommend that they get the antibody test because it is not going to change the management. They've already gotten the 2 doses. Whether they have the antibodies or not, they're not candidates for a third or the booster dose anyway. And therefore, we do not recommend checking antibodies after they've gotten their doses of vaccine. And another question many transplant patients ask is that, I've gotten both my vaccines. Should I still take all the precautions in terms of, social distancing, masks and stuff like that? And we repeatedly, bring up this model saying that there are multiple layers and all these layers, they have certain holes in it. And the only way to prevent an infection, because despite vaccination, these patients can get infections, is to continue to, social distance, continue to wear masks, and take all the precautions, all the COVID precautions that they were taking prior to vaccination. So to conclude, we recommend all solid organ transplant patients to get the vaccine. We also recommend that their household members and caregivers get vaccinated. We tell them to continue the immunosuppression that they were taking and not hold their immunosuppression because then they might be at risk for rejection. We also tell them to continue to use personal protective measures at this time and don't let their guard down. And there's no specific vaccine we recommend, although most of the time we favor the mRNA vaccines because of a little bit better data on those vaccines. And as I mentioned earlier, we do not recommend checking for antibodies because, again, it's not going to change the management of these patients. Most hospitals and most healthcare systems have a bunch of resources available for both patients as well as the healthcare personnel that are involved in the care. So I am very lucky to work at an institution where anything that I want to look up related to COVID is available at the hospital website, and many of the patients have access to this as well. So it is definitely helpful. These are some other resources that are available for transplant recipients in relation to COVID vaccine. And thank you so much for your time, and I'll be happy to answer any questions that you may have.
Thank you, Dr. Vasudev, for the wonderful explanation on the organ transplant vaccination. I would like to invite our dignitaries for the question answers. And before that, I would like to introduce who all are present here. So we have Dr. Ravi Naidu from Malaysia Medical Association. He's also the immediate past president of SIMAO. We have Dr. Ashraf from Pakistan Medical Association. He's the first vice president of SIMAO. We have Dr. Pillay from member of World Medical Council. We have Dr. Angelica from South Africa Medical Association. We have Dr. Jamal Chaudhary from Bangladesh Medical Association. We have Dr. Akhtar Hussain, again from South Africa Medical Association. Dr. Sajjad, Secretary General from Pakistan Medical Association. We have Dr. Mary from Japan Medical Association. Dr. Russell is from Australia and UNESCO. Dr. Bukhari from Pakistan. We have Dr. Monica from USA. Dr. Sanchita from IGCP Group, India. And we also have some more guests over here, who have been joining us over the Malaysia, Singapore, all those places as one of the listeners. So with this note, I would like to invite question answers. Okay.
Can I ask that question, please?
Yes, Mr. Ravi.
Thank you. Thank you very much, Dr. Vasudev, for an excellent presentation. My question is, your studies have been done with mRNA vaccines. What about the other vaccines, live attenuated and all this kind of vaccines? What is the response? Do you have any studies done on that so far?
Right. So, I have not looked at the data related to all the vaccines in transplant recipients. And, part of it is that some of these vaccines that are used in, let's say, Europe or Asia are not available here. So they've not been formally studied. I do know that there are studies that are ongoing looking at individual vaccines and how transplant patients respond to them. If I were to hypothesize, I would say that if we look at data on both the mRNA vaccines, it is very similar. So Moderna and Pfizer data is very similar. Therefore, if there is data available on, let's say, J&J, any vaccine that is similar to that, you can expect very similar results. But I think only time will tell. The reason is that even this data on Pfizer and Moderna vaccine just came out this month in JAMA. And this is because of, institutions like Johns Hopkins that have unlimited resources to do studies like this, because the vaccine the original studies never included the transplant patients, right? So it is really a leap of faith that transplant patients will say that, I'm going to participate in this study, even though nobody else has gotten these studies or have gotten these vaccines before. And I think institutions like Hopkins, they have enough clout that if they start a study like this, uh, patients will enroll and will have trust in that center. So I think we'll have to wait another month or two before data on other vaccine comes out.
Dr. Vasu,
Yes.
may I have a question?
Yes, Dr. Jamal.
Thank you. You have just mentioned about the immunogenicity, but what about the reactogenicity? Is there any data on that? So because New York Times some days back, they have published a note that this vaccine, actually Pfizer and mRNA vaccines, have more reactogenicity than the live attenuated or something like that. Is there any data on that reactogenicity in the case of SOTR?
No, that is true. So, if you look at the response rate in terms of antibodies, clearly the Pfizer and the Moderna vaccine, it's going to give you a response of almost, let's say, 95% in general population versus 65% for the J&J. And similarly, in transplant patients, when they use the J&J vaccine, a single dose vaccine, the response rate was barely 20-some% in terms of antibody production, compared to almost like 54% for the Pfizer and Moderna. So it seems like there is a little bit of a difference between these two vaccines. But again, most of these studies have only looked at the antibody response, and they have not looked at the T cell reactivity, which could be different.
Yes, Mr. Mukherjee.
Dr. Pillai, can I ask a question?
Yes, Dr. Pillai.
The outset, let me thank Dr. Vasudev for the excellent presentation and quite informative it has been. I want to know whether you have done some studies on patients who are on chronic dialysis, rather than, apart from the study you have done in transplant patients, those who are undergoing chronic long-term dialysis, whether there are any studies on that. Second, of course, is the booster dose. Are you recommending, or in the future will it be necessary, because the antibody levels seems to be a little on the lower side in transplant patients? And third, of course, is that even the small studies that have been conducted in India by transplant team shows that the mortality is almost up to 25% when they get COVID.
That is correct. So, I'll answer one question at a time. There have been studies done in the dialysis population. And one of the very good things, at least in the place that I work, is that almost 70 to 80% of the dialysis market is controlled by two companies. One is called DaVita, and the other one is called Fresenius. And they actually provided vaccine to the patients right in the dialysis units. And there were studies that were done, and the response rate to vaccination in dialysis patients is better than transplant patients. So they get almost a response rate close to 80-85% compared to 50% for transplant patients. And then the general population, of course, the response rates are 95 to 100%. So they are definitely better off than transplant patients in terms of getting the protection from this vaccine. The mortality rate, there has been a wide range of mortality from COVID in transplant recipients, and the numbers have varied anywhere between 20 to 30% within this population. And in terms of booster, I know that almost every transplant patient that I take care of is asking me if they can get the booster. The problem is that right now, until the FDA approves it, nobody can get it. Even if they want it, they can't, outside of a study. So if they enroll in a study, which I understand that Besides the French study that I showed you, even Johns Hopkins is doing another study where they're calling all these people who did not respond to the second dose and see if they would be interested in getting the third dose, and subsequently they'll see if they launch an antibody response or not.
Can I
Thank you.
ask the question? Can I ask the question?
Yes, please.
Thank you so much. First of all, it was very nice presentation, and especially about the very important topic of the immunocompromised patient. So many questions are asked from the Pakistan that I would like asked from you. The first question is that either when we are going advising the vaccine to these patients, may we stop the drugs which the patient is taking?
So the answer to that question is no. Like, do not tinker with their immunosuppression, because if they develop a rejection, it's very difficult to treat rejection during these times, because rejection means intensifying their immunosuppression. And if you do that, and God forbid they catch COVID after you've intensified their immunosuppression, they might end up doing worse. So therefore, we are saying, don't touch the immunosuppression, let it be as it is, give them the vaccination. And at some point, I am very hopeful that within the next 3 months, the booster will get approved. And once that happens, it's possible that we might risk stratify people and say that only patients who do not have antibodies should get the booster.
Thank you so much, because in Pakistan, so many consultants are advising that you stop the drug. Thank you so much. For another question is that in the different literature, it is advised that do not take the viral vector vaccine to these immunocompromised patients, especially the patients who are on transplant, because this viral vector vaccine can not only damage, there is a danger that because they are comprised of DNA, they can affect the DNA of these patients. What you will answer, and similar answer is with the Dr. Monica with us, because very important questions people are asking from us. Do not advise the viral vector vaccine to such patients. Thank you.
So, the guidance from the CDC and FDA at this point is that people should take the vaccine that is available to them. The data at this time that any particular vaccine would be worse for immunocompromised patients, I am at least not aware of that data. We obviously do not give live vaccines to transplant patients. Like, all the live vaccines are contraindicated, but they can get attenuated vaccines or kill virus vaccines. I'll let Monica answer if she is aware of any vector related issues, but to the best of my knowledge, at this point, there is no contraindication. And in India, I know both the vaccines that are available, the transplant patients are getting those vaccines.
No, because there are a lot of choices now that you can get either attenuated or mRNA vaccine. But my concern was that this viral vector, because you have also told about the Johnson & Johnson, the response is very poor. Johnson & Johnson is also viral vector. Can anybody among us answer my this question, that this viral vector vaccine can be dangerous in such immunocompromised patients?
This vaccine?
Thank you, Dr. Monica. I was expecting a question from you.
This vaccine is, 1 second. Can you turn down your volume on the computer? This vaccine as an mRNA vaccine will not cause any issues whatsoever. It is when the lipophilic ring of the mRNA goes into the cell, it's taken up into the cytoplasm, does not enter the nucleus, and has no bearing on the immunocompromised state. The mRNA then in the cytoplasm uses the host, the human ribosomes, machinery, the Golgi apparatus, packages the spike protein, and then presents it to the cell surface. There should be no concern whatsoever regarding mRNA use in immunocompromised patients based on its mechanism of action. And the viral vector vaccine, in terms of it causing less of a response, may benefit if there is further data on a booster dose in the future. But I think the issue, again, as we've discussed before, is access to vaccine and maybe potentially knowing our prior conversations regarding mixing and matching, especially with different vaccine mechanisms of action. So I had shown earlier at an earlier presentation, we had the AstraZeneca followed by the Pfizer vaccine, and they were able to mount a better response. So if your immunocompromised patients are getting the vector-based vaccines, it is possible that with the mix and match, possible third dose, booster dose with an mRNA vaccine, that they will benefit from that mix and match combination. So I think right now the first issue is vaccination, and we're running against time with the Delta wave that we're having worldwide. We don't have a lot of time. As this virus continues to mutate, there's actually conversations going on right now that are these mutants going to escape the efficacy of all these vaccines? So I think while we're having these conversations with our patients, the first issue is that we need to give the vaccine. And the second point then is later on, we can talk about individual efficacies of the vaccines. I hope I answered your question.
Thank you so much. Thank you so much.
You know, I would like to know, are the mRNA vaccines available in Asia?
Yes, to some extent, not much.
Yes, in Malaysia, it's available.
Yeah, in Bangladesh also we have Moderna and some Pfizer.
Yeah, we have only Pfizer here in Malaysia.
So, you know, if I were to make a recommendation based on my read of the data, if you have an immunocompromised patient, I would highly recommend to go with the mRNA-based vaccine because certainly the response rate is better, they tolerate them well, and there is enough data to show that, you know, they are safe in that population. So I would say that that should be the first choice if that's an option.
It's a good. Yeah.
So do we have any more questions or should we move with the country updates? So I welcome Dr. Chong. He's the chair for SEMAO.
My apologies, Dr. Vasudev, I thank you very much, but my apologies, I was stuck with the patient, so I couldn't hear what, but I'll look forward to the recording later. Thank you everyone for joining us, and always a pleasure to see everyone, and had a good listen to what you guys just mentioned, very interesting. So we'll just start with the country update. Can we start with what's happening in Bangladesh, Dr. Chowdhury?
Thank you so much, Dr. Chong. Actually, I must thank Dr. Vasudev for his nice presentation first. Then I say that actually in Bangladesh, the cases are actually near about 12,000 per week now. The last week is going on, and the number of deaths more than 200. So it's alarming here, and we are under lockdown, strict lockdown to some extent. But today, from tomorrow, for the export industries, it will be open. So we are maintaining the hygiene and others, the protocols. And so actually, it's more in other, I told you before, that is outside the capital city. So capital city is burdened with the cases actually coming from the districts actually. So we are really passing very bad time now. And the vaccination is now it's better. We are getting more vaccines actually, and the government has planned to go for 10 million doses per month. Thank you so much.
Thank you, Dr. Chaudhary. Can I listen? Can I hear what's happening in India, Dr. Pillai?
Thank you. The situation in India is that we still continue to be plateauing, and touching the bottom line is a distant reality for us. Immunization, almost 30% of our population, that is 45 crores of people have been immunized, and that program definitely is picking up in the country. Regarding lockdown and all, it has been regional variations. Most of the places, it is a locally confined lockdown or partly relaxed lockdown. Complete lockdown is not in any of the states. And another thing is that another drug trial is going on, niclosamide, which is used as an anti-helminthic on the basis that apart from the ACE2 receptor channels, the COVID virus also get into the stomach and all when the pH is low. And this drug has something to do with that. And the first phase of clinical trial is going on with this drug. Of course, it may take more time to know what's happening. Then mix and match, a scientific study has been started in CMC Vellore, a renowned hospital in the south of India. The ICMR approved study has been launched whether we can mix and match the vaccines, because the two vaccines that are very commonly used, Covishield and Covaxin, the Covaxin availability is a little less. So those who already taken Covaxin, they are being a study to see whether a Covishield can be, there is AstraZeneca, can be given. So these are the developments that are happening in India now. Thank you.
Thank you, Dr. Pillai. Can I hear what's happening in Pakistan? Dr. Sajjad or, sorry, Prof. Ashraf?
Sure. Thank you very much. First of all, I would like to appreciate and thank to our guest speaker, Dr. Brown. And I would like to share that the place where he presented his presentation, that is very much familiar to all of us CMO members, and it was pleasure to listen him, and very important topic. In Pakistan, we are at high, and the only metropolitan city, that is Karachi and the Sindh province, that is positivity rate is about more than around about it is 30%. And now the government is getting some restrictions over there as far as the vaccination program is concerned. We are now getting some vaccination in a better way, and government is very much adamant, and the restrictions are now over there to the restaurants and the transportation, that you have to have the vaccination certificate for your movements and activities, the social. Rest is fine, but we are on the height, and the variant what we are facing in Pakistan, it is a Delta variant, which is almost 80% of the cases are infected over there. Thank you.
Thank you. Thank you very much, Prof. Ravi, would you like to tell us what's happening in Malaysia?
Yeah, thank you, Dr. Chong. Okay, Malaysia, the situation is pretty bad. We are now, we are seeing around 16 to 17,000 cases daily, with more than 100, well, yesterday was 134 deaths. We are in a total lockdown, but despite the lockdown, the cases are all rising. However, the essential services are still functioning. As for vaccination, we have so far vaccinated 19 million people so far. Out of the 19 million, 6 million have got 2 doses. The 13 million approximately have got only 1 dose. So the government is now being very aggressive in terms of vaccination. The vaccines that are available in Malaysia are Sinovac and Pfizer. Some AstraZeneca is available. But the latest news we got from the government is they're going to proceed and make it more Pfizer vaccines will be made available in Malaysia. So our situation is pretty bad. We are in a total lockdown. We are not allowed to cross borders, which means within the country, we cannot go from one state to another state. And so things are becoming pretty bad, and the number of cases are increasing. And that is the situation here in Malaysia.
Thank you, Ravi. I'm sorry
you.
to hear my neighbor. I'm so sorry to hear all this stuff going on. Quite distressing for us here, your neighbors. Can I hear from Angelique, South Africa, or Dr. Hussein?
Morning. I will briefly, and then Dr. Hussein can also jump in. I just want to say that we are still seeing on a daily basis more an average of 13,000 and more. Recently, it seems that more cases are in the Western Cape than in Gauteng at this stage. We also have seen a vaccination program on the Johnson & Johnson, 1.5 million people vaccinated on that program. This has been going on since February. And then on the Pfizer vaccines, total administered was around about 5.9 million. With the first dose, 4.5 million, second dose, 1.4 million. So, I don't think we are really that good on the vaccination program, seeing that we started with Pfizer rollout already in the middle of May. So we are very worried about some of these vaccines. So for now, it still seems that Pfizer is better or give us good protection. They are now with the Johnson & Johnson, the doctors are now starting to ask those that have been vaccinated in February that they would like to have a second booster, because a lot of the doctors do get sick, although they don't get that severe disease. Unfortunately, we see some of them dying, even though they had been vaccinated with Johnson & Johnson. So again, we would like to bring in a second booster, but then using Pfizer. So we're still busy with the advisory committee on that. Then I just want to say, we looked at Sinovac and AstraZeneca, and currently there's not enough data from Sinovac on the Delta variant. So our recommendation for the third vaccine, if we run again into trouble with the first two, would be for now AstraZeneca, until there's enough data on Sinovac regarding the Delta variant. So maybe that's something that's been experienced in other countries as well, around secondary infections, and our death rate is still quite high. It's around about 500 per day. But I would ask Dr. Atkar if he wants to add anything. Thanks.
Thank you, Dr. Chong, giving me opportunity. Since COVID started in South Africa, total number is 2.5 million cases positive, 2.2 million recovered so far, and we have total 71,000 deaths. And we are on third wave, but the first and second wave was not that serious. Then third wave is really causing a lot of havoc here. And as Dr. Angelique mentioned about the breakthrough infection, we're really concerned with the Delta. A lot of doctors who got Johnson & Johnson getting the reinfected breakthrough infection. So we on a discussion about the boosting dose of Johnson & Johnson. That's all from my side. Thank you.
Thank you, Dr. Hussein. Dr. Russell, you want to talk to us before you have to run off?
Thank you, Dr. Chong, and thank you to Dr. Brahm Vasudev for that excellent presentation. I'm with regards to Australia, the issue here is that Greater Sydney continues to be in trouble, and I think 210 cases. So Victoria or New has come out of it, as you would know, Chong, with your son here. That's done well, and same with South Australia. But we have they've now decided that short, sharp, immediate lockdown is the way to go with the new Delta. New South Wales did not do that, and they are paying the price for that. So I think the Prime Minister has come out and it's taken the policy that we'll do this short. So today, Queensland has had 11, or they've had a couple of cases, but they've gone into a short lockdown till Tuesday with 11 local government areas. They had a couple of cases there. So otherwise, that's it. The other parts are under some restrictions in terms of numbers and at funerals and weddings and so forth and density. But I think we've kept. They still don't want you to go to anyone's house because that seems the main infection seems to be happening in houses. So that continues to be an area there. So in Melbourne, we can go to a restaurant, we can go out, but not to anyone's house. So that's as far as Australia. Thank you very much for all of you. And Saurabh, thank you for organizing.
Dr. Chong, may I have a question to Dr. Akhtar? Actually, he was mentioning about the Johnson vaccine, Johnson & Johnson. Because we are bringing Johnson & Johnson, so I have a query to you. Because you mentioned that there is a breakthrough, cases of breakthrough infections in the healthcare personnel, especially you mentioned the doctors. So you are thinking to go for the booster. So did you do the antibody for them actually? Or why you are so concerned about this year breakthrough more? Dr. Akhtar.
Dr. Hussain?
Dr. Akhtar Hussain.
Thank you, Dr. Jamal.
Yeah.
With what happened, we started with the Johnson & Johnson and the Pfizer for the non-healthcare worker. The reinfection, those who got Johnson & Johnson after 4 weeks, 6 weeks, and some of them after 12 weeks, numbers are increasingly high in the doctors and nurses and paramedics. We didn't do antibody test because there are no need to do it because we are getting now infected. So no, we haven't done, and that trial is going on. So we may get the information quick, very soon.
Okay.
But here, we have used AstraZeneca, and the cases are very less now in the frontliners, especially the doctors. We are seeing less death and less infections also, we can say.
Yeah, thank because AstraZeneca is a messenger one, and the Johnson & Johnson is a vector one. So there may be a big difference there.
No, AstraZeneca also it's also a vector one. AstraZeneca, yeah, it's also a vector one.
AstraZeneca and Johnson & Johnson are viral vectors, and Pfizer and Moderna are mRNA.
Yeah.
The only difference is the dose.
That's right.
Okay. All right. Thank you very much. Can I just share my screen to update you all on what's happening in Singapore, because there's some interesting data that came out. So I just want to share it to you all. Okay, this is my Singapore ministry data that you can see, and okay, we have about 2,000 cases of Delta since the outbreak started early on the 11th of July. And very interestingly, you can see the squares here, whether they are linked or unlinked, and quite a number of unlinked cases. The last few days is just holding steady at 130 a day, despite our very, very efficient contact tracing. So we're having some problems getting a handle on Delta. But what's interesting is this data here. This data shows you the 2,000 cases of Delta that we had. And if you look at the first 0.1% need oxygen if you're fully vaccinated. If you're partially vaccinated with just one dose of Pfizer or Moderna, it's about 2% that need oxygen. If you're completely unvaccinated, it's 4.6%. So the oxygenation needs have risen, with Delta. All right, so this is what I wanted to show everyone. In terms of vaccination numbers, we have vaccinated 76% of our population with one dose at least. and 57% of the population have received 2 doses. So that's where we are at the moment. We have not spoken about the booster dose yet. So that's where we are. Our seniors continue to be a problem, those above 70, and we have 22% of those above 70 who are not vaccinated for various reasons. So we're really trying to push that group to be vaccinated because they're very vulnerable. ICU capacity is still all right. You can see from this chart here, there's only 3 of them in ICU. But the rest are, so it's still quite manageable. So that's what I have to share.
Mr. Chong, can I say something?
Yes, Dr. Sajat, I wanted to ask you to say something just now.
Okay, thank you very much. Thank you very much. Good morning, everybody. Actually, I just add what the Nizami said here about the situation of Pakistan. Actually, we have in Pakistan, the number of cases increasing gradually all over the Pakistan, and mostly the cases are Delta variant, what you are talking about. And the problem is that in the province of Sindh, particularly Karachi, at Karachi, we have lots of patients here of Delta virus, Delta variant. And what we have collected the data in Karachi that the patient who have admitted in hospitals and those who are in their home, the 85% are non-vaccinated. 85% to 90% are not non-vaccinated, and 10 to 15% are vaccinated, which is a good sign. And we are just convincing the people in Pakistan that please go for the vaccination so that you can protect yourself and your family also. So this is the situation, and the tests are what I have collected the data from the laboratories that at least 35 to 40% positivity rate is here in Karachi. So the situation is going bad. But the good thing is that the government of Sindh have imposed the lockdown, not the complete, but the partial lockdown from today till 8th of August. Hope for the best. And this is the all situation I would like to add on. Thank you very much.
Dr. Sajat, thank you. Good to hear from you. I wanted to ask you to say something just now.
Okay. Go ahead.
Anyway, thank you everyone for that, for coming on board and our weekly meeting. And I'm so sorry I didn't hear Dr. Vasudev's presentation, but I will look at it afterwards on the recording. And
Chong,
from what I hear,
can anybody cover on the, like, I think there was a news for the China recently that there's a sudden spike in the China in the last 24 hours.
Yeah.
And even though the cases are still in hundreds, but it's a very big concern for them for the sudden rise, and especially the Delta variant. Is just anybody who can throw light on it?
Alvin would have
Dr. Pillai here. The information is that some of the people who have been cleaning a plane which has come from Russia, the people who are cleaning that from the plane, they have transmitted the disease. That is what we know so far, and there is complete lockdown in that particular province.
Dr. Monica or Dr. Baum Vasudev, actually, you can answer my question if I have. Actually, there is a report that the Pfizer and Moderna vaccines antibody is just depleting actually in just after 4 to 6 weeks. Sorry, 6 to 8 is like that, I think. Is it correct?
They showed that there was a fall in antibody level or protection after 6 months. I believe that the protection went from 95 to 82%, which is still considered very good. The biggest
is it 6 months
actually,
or is it weeks or months?
Months.
Okay.
But the biggest news from the United States that came out today was related to the 4th of July festivities, where they had a super spreader event of vaccinated individuals And what they found there was that those individuals who were vaccinated had the same viral load as those who were unvaccinated. So the difference between vaccinated and unvaccinated is how sick you get. But what this study showed, which is now changing and adding confusion to masking and social distancing guidelines, especially as we're on the eve of school starting, is that those who are vaccinated are catching the Delta variant. They have the same viral load as those who are unvaccinated and are potentially spreading it to others. So this is like the biggest news that came out on a Friday here. I have always felt that we needed to use a Swiss cheese model where we needed to address issues as they come, but address everything at the same time, which is we need to continuously mask whether or not we're vaccinated or unvaccinated. We have not hit the level of vaccine confidence that we need to in the time frame that we need to. The Delta variant is the biggest stress test that we have to the gains that we have made so far. I think that we're going to be seeing more news rapidly in the next few weeks. And this is definitely a very fluid, very moving target in terms of the guidelines that we expect. But I think, again, the bottom line is those who can get vaccinated, please vaccinate them, use whatever vaccines that you have available and deal with the minutia later. I think it's just, we are in a race right now and we need to keep vaccinating. So thank you for all your efforts.
Dr. Vasudev, do you have any idea about the basis that Israel is just vaccinating their more than elder people for the third time? What is the basis?
Yes.
Of that?
Yes,
So,
was that in Israel that they were actually giving the booster doses to their elderly? There is a phenomenon called immunosenescence, where your immune system isn't as robust as you age. It's one of the aging processes. And by giving a third dose, they may benefit from them. But I think there's also the issue of giving the third boost or addressing the booster dose right now is premature, while you still have a significant population that has not even received the first doses. And I think that's holding up. I think definitely a booster dose is required, but I think also timing it to make sure that we're giving it at the right time in terms of the duration since people have received the vaccines. So we were in 1A, phase 1A, and we got the vaccine in December and January. Most of the general population started receiving the vaccines March, April, May over here. Our children started getting it in May, June, July. So then as we start looking at the booster doses, you're similarly going to have to give the same time frame for everybody. I think the critical need now is to get those people who are indecisive to be able to get the vaccine. There are those who are absolutely going to refuse and those who are contraindicated. But we need to be more worried about making sure we have enough vaccine and we can get it out to the population.
Thank you.
Thank you, Monica. It's interesting because
can I ask a question, Dr. Chong? Can I ask? I just have a query just to confirm news that a Sri Lankan professor has announced, or what you call that they have done a research that the Sinopharm vaccine is the only vaccine who protect the Delta variant only, and no other vaccines are protecting. Is it true, or anybody can confirm that the Sinopharm is the only vaccine is protecting against the Delta variant?
I think, Dr. Satya, if you saw the data that I showed just now, the vaccine.
I missed it.
Oh, yeah, against Delta. Now, just quickly, I just did my CPAS test just now. So I'll wait for the result next few days. That's the neutralizing antibody. But from our own experience in our own practice, where we did CPAS for our patients, those above 60, those who have chronic diseases tend to have much lower levels as opposed to, the younger group. Just as a interesting feedback to what Monica just said. Okay, I think we've come to the end of our session because the other meeting is here already. So it's time for us to take our leave. Thank you all for the wonderful session, and I look forward to seeing you on next Saturday.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Thank you.
Thank you to our speaker, although I didn't have a chance to listen to him. Thank you very much for your wonderful presentation. Thank you.
Thank you everyone for joining in. See you next week with a new session, and thank you.